Good afternoon, everyone. We are here in Hotlanta. We're very excited to talk with you about value-based pricing, a smarter approach to reference-based pricing. Last month, MAP was honored to win a Health Value Award for the validated category, Reference-Based Pricing, Bundled Payment Services. This is the second year for the award, but it's the first year for this category. MAP is very proud of their dedicated team for doing what's right for the participants and putting their needs first. MAP is thankful for its partners and colleagues like you today in helping them change the healthcare landscape to value-based care. We are all in this together. Let's take an opportunity to meet our expert speakers. Ed Dillabo, President of MAP Medical Advocate Program.
Good afternoon.
And Wayne Soud, CEO of Strategic Benefit Resources.
Good afternoon.
Ed, tell us a little bit about your program.
All right. MAP has been in reference-based pricing for several years now, and we implemented a new program that addresses some of the issues that we see in the marketplace. We do, beside the MAP program, or what we're known for in advocacy, we also do pre-certification, we do case management, we do what we call direct pay providers before services are rendered, we do legal support, and we do repricing of claims and audit of those claims prior to going to the TPA for payment. So we are basically a full-service reference-based pricing, excluding the services third-party administrators provide for this type of program.
And Wayne, tell us about your company.
Strategic Benefit Resources is an expert in self-funding and stop-loss insurance, and we partner with brokers, consultants, and third-party administrators in helping them navigate the self-funded health plan world, including the placement and management of stop-loss and risk insurance.
Today we want to accomplish three things. First, our goal is to share information from our experiences and for you to learn something new. Number two, our challenge is for you to actively listen. Please put away your distractions for this 30 minutes and think differently. Number three, our intent. We would like you to get to participate with us and have a good time. So we're going to be moving on to the slide now. With our current healthcare system, we have been very provider focused. And what does that mean? When you go to the doctor, just think about it. You're sitting in the room and your doctor is looking at his or her computer, and never looking you in the eye. We want to move to a more participant-focused type of care. Ed, what does that mean to you?
Well, under the current system, the carriers are basically focused on the hospitals and physicians in their relationship to provide a product to the employer. In reference-based pricing, the network is not emphasized, and so the emphasis should be always on the participant. How well do you educate that individual before the effective date and during the time you have them enrolled, how to focus on the physician, and instead of the physician, the participant. So that's what participation means, is focusing on the medical education of that individual of how to navigate the delivery system.
Okay, next we're going to be talking about decision models. So when you think about the decision model, the doctors are focused on, we're having average medical care in the community, and we want to get to the best medical care in the community. When you think about it, when you're on a network, there are so many providers and you're not sure what kind of care you're getting. But we want to get to best medical care. Ed, how does that work into your program?
So when we're talking about average medical care in the community, most of the carriers have every physician in every hospital participating in the network. So basically what it means is you're getting the average medical care of the community. Nothing worse, nothing better, just average. In our system, we're focusing on who are the top 5% of the physicians based on outcomes and quality measurements. And so what we're doing is steering the patients to the best physicians and providing the best medical care in any community in the United States. Best medical care, again, is based on outcomes.
Next is the belief system. Traditionally, we've been talking about more is better. When you think about in the news about the overuse of CT scans and increased technology. We want to get to a system where we're more proactive to avoid the misuse and over and underuse of procedures and treatments. Ed, how do you avoid the misuse of procedures?
The most important thing is to have an individual person participate in our program and talking to a nurse. What happens is about 40% of the time, people are self-analyzing themselves, going in the wrong direction. And what that happens is you go out and spend a lot of money on healthcare that is really misused in our system. So by talking to a nurse and being educating on the guidance of how to get the right care, going to the right doctor the first time is really the best example of misuse.
Next would be the goal in the healthcare system. Traditionally, physicians have addressed illness because they really are educated to treat and diagnose. We would like to get to a point where we are focused on improving health outcomes. Ed, how do you think we can improve health outcomes?
Well, it's quite simple, actually. If you're able to profile every doctor in the United States and knowing which doctor has the highest volume, has the best outcomes, is credentialed, doesn't have malpractice or disciplinary actions, by going through a process of identifying those physicians, if everybody went to one of those top 5 physicians, our healthcare costs would be substantially less. And again, not everybody has that information. We're one of the few companies that has information on every doctor profile in the United States.
Now let's get to the meat and potatoes, payment. We have been in a system where we are paid fee for service, and we know how well that's going. We would like to propose moving to a more value-based or reference-based type of payment mechanism. Ed, can you speak to value-based pricing?
The difference in value-based and reference-based is quite simple. Both are paying a fee schedule or a known fee schedule. In this case, most of the people use Medicare. So they use a basis of Medicare plus or minus off that fee schedule and use that for payments. Now, again, that's a pricing mechanism. If we're talking about value, value has to have some sort of quality or outcome measurement. And so when we put with the pricing, identify who are the best outcome-based physicians, then you're creating value. And that's what we say value-based pricing, value of the doctor, pricing of Medicare. Together, that's going to have the best results financially.
And Ed, how does payments affect balance billing? We hear a lot about balance billing issues with reference-based pricing.
Yeah, one of the things that's critical about reference-based, and it gets everybody's attention, and especially when you're first looking at this type of program, the biggest pushback is balance billing. The hospitals are going to be balance billing the patient. Well, there's always legal support, but the thing about balance billing is the pushback. There are certain hospitals and providers do not accept reference-based pricing or having no network. What we've been able to establish is what we call direct pay. It's a very proactive, very friendly system that deals with physicians both friendly and unfriendly, and so paying the providers before the services are rendered. This allows us to be able to avoid any type of balance billing program. Again, this is balance billing right now is mostly gets all the attention of the hospitals. And so we've been able to bundle price the hospital with the hospital-based physicians and surgeon if there's no network, putting together a payment back to pay the providers, again, before the services are rendered. This produces the lowest cost to the employer in avoiding any kind of balance billing, especially to those providers who are unfriendly.
And I could see that how that would benefit providers too, in that they're getting paid up front, which is not happening in a fee-for-service type of arrangement.
Let me kind of summarize this first slide. In reference-based pricing, we need to educate that participant. You need to get a commitment. Now, sometimes we use a pledge card where we have the individuals sign off on what they're committing to. So there's no misunderstanding, because you're really trying to focus on the participant changing how they go about buying medical care. The second thing is you have to be able to steer patients to high-performing doctors. The only way you can steer to high-performing doctors is to have each individual doctor profile based on outcomes and measure it against other doctors on a severity-adjusted basis. And we'll get into that in a minute. And the third thing is the payment mechanisms. When you have pushback, how are you going to get that patient to be seen by that doctor and hospital without having to ask them to go see another doctor or hospital, and how to avoid the balanced billing?
So one of the things that when you're looking at reference-based pricing, I know one of the questions we always get is, what is the equivalent of a reference-based pricing point when compared to a discount off of a billed charge? And so as we kind of set the stage for reference-based pricing and what the opportunity is, we kind of wanted to talk a little bit about the differences between a average PPO discount and a reference-based pricing point. So when you look at a reference-based pricing, and again, depending upon how you structure that reference-based pricing, whether it's a percentage of Medicare or a cost plus, or when you get into the percent of Medicare, you'll see a lot of folks where they'll have different type of Medicare pricing, whether it's a fixed rate at 140% of Medicare or a range of 140% to say 200% of Medicare. One of the things we wanted to do is provide you with some kind of averages on what that equates to in an average discount off of a billed charge. So when you're looking at 140% of Medicare, with the average PPO discounts ranging from 25 to 50%, at 140% of Medicare, you're looking at approximate average discount off a billed charge of 72%. At 160% of Medicare, you're looking at about 68% discount, and at 180% of Medicare, 64% discount. So this gives you a good kind of basis and reference point when you're comparing to an average PPO discount, what you can achieve and what the opportunity is in moving to a reference-based pricing model.
The next slide is an example of MS-DRG. And what MS-DRG stands for is most of us always use the term DRG or diagnosis-related groups. But Medicare changed the rules several years ago, and they added MS, which is Medicare severity. And so that you have any procedure, like a gallbladder removal, or some people will call it lap chole, there are 3 different rates of reimbursement for the exact same procedure. Let me repeat that. When you have a physician doing a lap chole, there's only one code. But in a hospital, there are 3 different reimbursements, depending on the severity of the patient. Now, there are some up to 6 different reimbursements, but in this example, gallbladder, there are 3. So the first MS-DRG is $419. You see the without MCC and MCC, that's without complications or major complications. So you look to the right, it's $98.59 reimbursement at 140% of Medicare. 418 is with CC with complications. The reimbursement for over is $13,703. The 417 is with major complications or MCC, and the national reimbursement for Medicare at 140% is $21,619. The weighted average of those is $12,487. With MAP, our weighted average, instead of being 57% no complications, it's 85%. So the facility costs associated with these doctors, our facility cost is going to be $10,968. The average is $12,487, or about $1,500 difference in facility costs. The importance here is understanding that the hospital charges different amounts, but the reimbursements are different based on the severity of the patient. Okay. The next slide, again, we're looking at the total knee replacements of the top 4 hospitals in the United States based on volume. This is MedPAR data. The first hospital is NYC facility. That's New York Specialty Hospital, the busiest hospital in the United States for joint replacements. There's another hospital in Delaware. This third one is in Duluth, Minnesota. And the fourth one is in Portland, Maine. You wouldn't expect some of these names to be up there, but they are the top 4 hospitals based on volume for a total knee replacement. The bubbles here underneath each of the hospitals are doctors. What we tend to look at is not the bubbles, we look at the average. So in NYC facility, especially hospital, the average bill charge is $71,000. And we usually compare that hospital to other hospitals in the region. Delaware, $30,000, Duluth, $41,000, Portland's $50,000. But what's more important is look at the range of the charges between each of those bubbles or doctors. So an NYC facility, the range is on the top $84,000, again, the average $71,000. Look at the low end, $45,000. There's almost a $40,000 spread. There's 22 at Delaware, there's $41,000 spread in Duluth, and almost $95,000 in Portland. The range is very significant in any hospital in the United States based on the doctor's OR time, the doctor's length of stay, the doctor's implant they pick. That's what drives the difference. In our MAP preferred doctors, what we tend to look at is the best outcomes in physicians. And so these greens that are popping up here, those are our doctors. You notice they're all well below the average. And again, what you're focusing on in reference-based pricing is the best outcome, again, for value, but also understanding what the balance bill is going to be. Is the balance bill going to be $20,000, $30,000, or $100,000? Well, in Portland, if you use that doctor on the top, $125,000, you're going to be at least $95,000 more than the doctors we picked on the lower end. So again, you can compare hospitals all you want, but there's more variation within a hospital by doctor than there is between doctor, hospital, and hospital. The next slide, again, we're talking about total knees, and sometimes we talk about knees because it's an easy procedure to understand, not fun to go through, but it's easy to understand because it's very common for the commercial population. Now, this is cost per facility for inpatient stay. This is a little bit like the prior slide. You have Morton Plant Hospital, an 800-bed hospital in Clearwater, Florida, and we looked at 2 physicians, one ending in 41 and the other ending in 02. The volumes is very significantly different, and of course the green is our MAP preferred doctors, again our high performance network, and the difference is 254 versus 26. Length of stay is a little bit of difference, but look at the bill charges, 54,000 versus 70,989, say 71,000. But again, there's a spread difference between the bill. We always look at the balance billing amount. If you pick a doctor and you don't know the balance billing amount, you're asking for trouble. So we have to understand before we give out a name, which hospital or facility they go to and what the balance billing amount is going to be. Look at the very bottom one, the East Countryside. You have a doctor who performs 100, which is our preferred doctor. And if you look over on the very far right column, the balance bill is going to be $34,104. But if you below that, if you pick the doctor who does 53 or ending in 61, his balance bill or her balance bill is going to be $123,650. So again, within the hospital doing the exact same procedure, but if you'll notice the third column, look at the length of stay of that one doctor that has a high balance bill. And again, our criteria is you want to at least do 50 procedures a year, and that doctor evidently does at least 50, but his cost is so out of line compared to everybody else, we couldn't use him because of the cost of the implants, the cost of his length of stay, and the cost of his OR time. And again, you want doctors who are fast, get people in and out, are cost effective, and have the best outcomes.
So one of the things as you're looking at value-based pricing or reference-based pricing is you always have to look and say, what is the impact on the stop-loss insurance pricing in a self-funded health plan? So when you look at reference-based pricing, it can mean a lot of different things to a lot of different people, and it's all depending upon how you structure it and how that structure is communicated to the reinsurance markets. So the first one that's a major influence of the stop-loss pricing is going to be the structure of the reference-based reimbursement arrangement. Whether that's a flat % of Medicare, whether it's a range of Medicare where the company can actually pay up to, say, between 140% or up to 200% of Medicare to try to minimize member noise, or it's a cost-plus pricing arrangement if Medicare pricing is not available, or even if you have direct contracts with certain providers or on certain services, i.e. dialysis and other services, all of that has an influence on how the stop-loss markets are going to price out that risk. The other component that drives that is also the quality of the providers. And as Ed mentioned, if you have a higher quality provider that's at a lower cost, that has better outcomes, that's going to have an influence on the stop-loss market's pricing of risk. The second piece is the reference-based pricing vendor and how that vendor gets paid. And this is important because, as you'll see out there with a lot of the vendors, you'll see some that are getting paid a % of savings, or some that are getting paid a % of billed charges, or some that are charging a per employee per month administrative fee for the service rendered. That has an impact on how stop-loss carriers price. So, for example, a % of savings or % of billed charges is actually a reimbursable expense under a stop-loss policy, whereas a per employee per month administrative fee is not. So that will definitely influence how the markets price out the premiums and price out the coverage terms for the stop-loss policies. The other items that kind of influence the pricing is ultimately how you structure and what you apply a reference-based pricing to. So, for example, if you're looking at inpatient and outpatient facility, or you're looking at inpatient, outpatient facility and professional services, that all will influence how the stop-loss carriers are pricing out the risk. The next is plan design. Plan design, you want to make sure you have a plan design that creates the right steerage and right incentives by the participant in a reference-based pricing model. And then fifthly is the pharmacy benefit manager. You definitely want to have a pharmacy benefit manager that's integrated with the overall approach. And then lastly is the plan document language. As you build and structure your reference-based pricing, you want to make sure the language in your plan document reflects the intent of the program and how the program is being structured, because ultimately that is what a stop-loss insurance carrier will look to as a guiding document in the reimbursement of a stop-loss claim.
We're going to wrap up today talking about a value-based approach. Really 3 key elements: motivation, how do we motivate participants for compliance, better compliance, ultimately resulting in better outcomes. And Ed is going to speak a little bit about that.
When you're talking about motivation, we have to address how do we go about educating the participants. It's not always about the benefit design. It's about how the individual needs to talk to a doctor, hospital, have a navigated delivery system. That's critical. Now, again, the educational program should always be measured as to how many participants are actually using the advocacy services and talking to the TPA. I can tell you that in the last 2 groups we've enrolled this last 2 months, over 98% of the participants have actually called MAP before the effective date of the services. And that's critical, is understanding what their medical needs are and working with the patient one-on-one to educate them on how to go about navigating the delivery system under your new plan design. The compliance is important because it depends on what type of benefits we're going to have. And so, again, do you want a gatekeeper concept, or do you want to have an open access network or no network? Those are things you have to consider, but at the same time, you have to balance the cost of the benefits. And probably, we think is one of the most critical things is being able to steer the patients to the right doctor, to the right facilities. And under a gatekeeper concept, you can do that very easily by not identifying the network and having the participants call in. Now, again, not every employer is going to be wanting to go in that route, but again, you can go to the gatekeeper, or you can go to no network and let people do whatever they want. But again, the question always comes back to is, what's the balance billing issue? How many dollars are we going to have in balance billing depends on what type of program you select.
We hope you enjoyed our program today. We thank you for joining us. You've all been waiting for the secret formula, and here it is. Value-based pricing is cooperation plus collaboration plus communication. I like to call it the 3 C's. Let's continue the conversation. I think we had a a very exciting program today, and I hope that you all learned something new. You can schedule an appointment with the MAP Medical Advocate Program on our website, mapmedicaladvocates.com, or directly email us at info@map-health.com. And you can reach Strategic Benefit Resources at the telephone shown on your slide, or email them directly at info@strategicbenefitresources.com. Ed, let me ask you this. We haven't talked about pharmacy at all, and every time we open the news today, we see drug prices are soaring. What type of solutions are there out there, or what can you talk to us about regarding high-cost drugs?
In reference-based pricing, we've developed several different programs with pharmacy, one of which is specialty cost or high-cost drugs. What we've done with some PBMs is they fill the first 30 days, and after the 30 days, we actually coordinate with the patient and doctor and fill those drugs at much lower cost. Again, sometimes the medications will be purchased locally, or other times it may be purchased from a global distributor or outside the country. I think this has gotten a lot of attention in the last year or so. High-cost drugs, what are the alternatives? Again, we work with patients on every medication. 87% of the people that we work with that call us in our program, we're able to save money, whether it's getting the medication for free or getting the medication from a different pharmacy. Again, 87% of the people are saving money through our programs and saving significant amounts as well.
Okay. Thank you very much for attending today, and we hope you have a pleasant day today. Thank you, everybody.